Think Forward. Think Research Channel.
The oldest baby boomer turned 50 in 1996. That was last year, the boomer year for menopause. The number of women aged 45 to 54 will grow by 73% from 1990 to 2000. And the number of postmenopausal women has tripled since 1871 and now represents 1/2 of all women. Now note that the average life expectancy for women, and you don't need to take notes, every PowerPoint slide, including the ones I took out because the lecture was too long, you got in your syllabus. So just sit back, eat, listen, and try to enjoy the hour. The average life expectancy is 75 years for women now, and approximately 90% of women reach 65 years of age. 30% will reach 80. Most women will spend a third of their lifetime postmenopausal, and 1 in 2 will spend 30 years postmenopausal. Now, the average age of menopause is 49 to 51 throughout known history. It's actually when your menstruation starts that changes with nutrition and other factors. But menopause itself is a fairly solid age. It can change, but it's genetic factors. If it runs in your family, and the females in your family have an early menopause, then you, in fact, may have an early menopause. But for the population at large, it's going to be 50 to 51. In the United States in 1900, they say that the average female didn't live past 50. Now, you have to understand from a statistical point of view that that is a distorted number because there were so many babies, female babies, that were lost due to infection at that time. So what it did is it drew down the numbers. But in all reality, the women that did live postmenopausally did not represent a significant portion of the population, despite the fact that the death of young children has pulled down the numbers when you speak of the average lifespan of a female. In 1990, 80% of the females survived to 65. And again, 3,500 American women, starting last year, which was the peak of the baby boomers, are going through menopause daily. Now, this is more significant in Western Europe and Canada because of increasing longevity, high birth rates after World War II, and a very large menopausal population, which are going to make increasing demands on health care. Now, how will this impact our practices? For anybody, I pushed forward, nothing happened. Okay, good. For anybody in this room, including anyone in practice who's 45 years of age or under, these statistics will be true. And that is that the majority of your practice in family practice and internal medicine, and according to Summer, 3/4 of your practice will be postmenopausal women. So if you do not like women's health, and particularly if you don't like postmenopausal women, I can suggest a number of fields you can go into in medicine, including radiology, orthopedics, where your 3/4 of your whole practice won't be a postmenopausal woman. But keep in mind, wherever you go, your practice is going to be largely geriatric. Now, what about the economic impact? Well, the economic impact is significant, and because this is a medical student audience, I don't want to just do psychiatry. I actually did a full internship in medicine at Bellevue before I saw the light in my exhaustion at the end of the year, having been on call every other night for a year, but also having been interested in psychiatry. So I changed over. And I really want to emphasize a few things that harken back to my medical training. You know, menopause is many things for us. It's preventative health for osteoporosis, it's preventative health for cardiovascular disease, it's preventative health for genital urinary problems, it's increased utilizations of services in the perimenopause, which is of interest to psychiatry. And the focus of this lecture is how the perimenopause affects brain functioning. And then, of course, there's the complications we cause by trying to treat all of the above by giving hormone replacement therapy, which is a less than perfect treatment. Good for most, not good for all. So all of that should be kept in mind when you think menopause. Now, the World Health Organization defines menopause as the permanent cessation of menstruation resulting from loss of ovarian function. However, perimenopause is a different concept. It includes the period immediately prior to the menopause with endocrinologic, biologic, and clinical features approaching the menopause, and at least the first year after the menopause. That means that even if all your numbers on labs are normal, if you're having a hot flash, that's enough to qualify as being perimenopausal. A dry vagina is enough to qualify as being perimenopausal. An increasing FSH without those symptoms can qualify you as perimenopausal. A sputtering ovary, that means not a regular cycling of your period in your 40s, can qualify you as starting to be perimenopausal. So that it's not a strict biologic definition, and that's very important to remember, because a strict biologic definition doesn't work. Follicle-stimulating hormone alone won't tell you. There's a wide variation of normal. We do not have prospective measures of every woman's FSH. So as a result, we have population norms. So a woman can come along and she can be in the perimenopause but appear to have a normal FSH. Now that FSH may not be normal for her. Her FSH when she was 25 or 30 might have been much lower. But we don't have prospective measures, nor do we really understand the true sensitivity of the brain for dropping estradiol levels. So whereas one woman might have her FSH go up with subtle drops, another woman might not. So for that reason, you need to look at the whole picture. And postmenopause is defined as a year, a period of 12 months without menstruation. The Calistogas, they went. I just need one in case I start to get too dry. Now what I'd like to do is give you a little history. Menopause is not popular in medicine. In fact, thanks a lot. In fact, menopause is pretty unpopular, period, among women and among society. And there's some very good reasons for that. Now, it may become more popular because it's highly funded, and things that have money become popular in this day and age. And there is lots of money to look at menopause from government sources as well as pharmaceutical sources. So that may actually have more impact on the world's view of menopause than anything else. But let's look at why menopause has had such a bad name. Well, the ideological environment in which a woman experiences her menopause is actually a function of prevailing Western ideas. I went through the literature, and I also went through other people's sources through the literature. So this is an amalgam of different people's work. And I pulled out 6 central themes prevalent in the medical literature of the last 100 years to give some feeling to you of the distortion we have on views of the menopause. There's 6 prevalent themes in the medical literature on menopause. One is that women are incomplete until the menopause. A reflective quote for that is from Marinon in L'Age Critique in 1934. He said, "Who as a man of his time viewed women as incomplete beings, viewed the evolution of female physiology after the menopause as favorable, in the sense of moving towards a more perfect, i.e. a more masculine state." Another theme, some of you may be too young to realize how bizarre these comments are. They may not have affected your life, but anyone over 35 or 40, realizes that these things have been true myths of their time. Another theme is that menstruation and cessation is the same as suffering and the termination of suffering. Helena Deutsch in The Psychology of Women in 1945 characterized menopause as partial death, or la dangereuse âge. And a dictionary entry in 1978 describes the climacteric as a critical period in a quite literal sense as a time of danger for women. Then, of course, there's the notion of a deficiency state implying loss. Rhodes, in his article Minimizing the Menopause in the American Geriatric Society in 1967, describes the physical and mental aspects of the peri- and postmenopause as a chronic and incapacitating deficiency disease. Then there's the theme that the climacteric or menopause is simply a luxury phenomenon. Symptoms of the menopause is a phenomenon of privileged women. An example is a dictionary entry by Van Dale defining hot flushes as a more or less imaginary ailment presented by ladies of the higher social classes and characterized by symptoms of hysterical or depressive nature. Then there's the theme that the working woman has no time to indulge in complaints. Michael Wolfram, in the journal Gynecologie Psychosomatique, 1964, wrote, quote, "Idleness is the source of all evil. Every woman has the menopause she deserves." And lastly, there's the theme of a problematic menopause, proof of a weak personality, a lack of character, and symptoms are considered somatic manifestations resulting from psychic changes only. What's the problem here? The problem is there's been an intermingling of societal beliefs and medical views. Society has developed prejudicial thinking towards women. Now, I want to point out to you, it's not specifically men. Men are a product of the society they're brought up into. What? Can you hear? Okay. It's not specifically a function of men. It's a function of the society, and it took us 2,000 years to arrive at these views. And the problem is we need to debunk them. What I like is a quote from Mary Chamberlain. She said, "Medicine, like war, is an extension of politics," and that's along the theme of the next lecture you're going to have on the problems in managed care. Because I would tell you, managed care is changing and changing as a force of economic forces, some of which are completely out of control, even of the doctor-run HMOs like Kaiser Permanente, because of capitalist forces. So what's the problem with menopause research? I like Mark Twain's quote because I think it's quite accurate, and it's not what you don't know that hurts you, it's what you know for sure that just ain't so. And I think that's true until about 8 years ago. I would say the research of the last 8 to 10 years has been excellent. So, where did this all come from? Believe it or not, I am in the next 5 minutes going to take you from the Greeks to the crash of the stock market, but not the crash that almost just happened, but the crash from the early part of the century. And then we're going to start on neurotransmitters. But I think neurotransmitters, out of the context of history, is very dry, and it doesn't give you the value of how important this research and this information that is really of the last 10 years in biologic psychiatry and neurology, and how important it is in the context of what we used to know or not know. Now, the ideological connection between mental illness and reproductive function, obviously Jane doesn't like it either. This is a very insightful little child. She too understands this. The derivation of the word hysteria was from the Greek word for uterus, or hystera, and the idea of culture and nature being separate also came from the Greeks. Now you might wonder, what the hell does this have to do with menopause? Well, I'll get you there. The Greeks said that women, and by default femininity, were associated with nature. But how did they define nature? Nature was associated with the area of intuition, emotions, unpredictability, the lunar darkness, mystery, and magic. And men, and by default masculinity, were associated with culture. But how did they define culture? Culture was associated with logic, reason, control, the solar light, freedom, and intellect. Then along came Hippocratic writings, and they said that women were governed by the womb and therefore naturally incapable of logic and reason. Now, how did they do this? They had theory A, that the womb governs the woman, completely unproven. They had theory B, where they defined nature as being feminine and culture as being masculine, and then they defined culture and nature. And then they said, therefore, theory C is true, which is women are governed by the womb and therefore naturally incapable of logic and reason. Now, there's someone of this century who was very brilliant in his time, but many of his theories suffer from this in my field, and that's Freud. He was a very, very brilliant thinker. But if you look at what we know today, and you look at some of his theories, they suffer from it. They suffer from not being based on true research criteria, especially if you look at his theories about hysteria and Oedipal conflicts. We find out that his patients, in fact, were the victims of incest and were telling the truth on the couch. They weren't fantasies of sex with their father. Now, what about the Dark and Middle Ages to the crash of the stock market? In the Dark and Middle Ages, we have the exclusion of women from access to learning. And again, the argument was based on this initial Greek argument. And the initial Greek argument was continued into Catholicism through the Middle Ages. So there was little change. If anything, it was made worse. From the 12th to the 17th century, women were excluded from spiritual learning with the same argument. And here's the important theme I'm trying to teach you, which is the reason why we went through this history. The theme is that a woman's body is seen as a malevolent force. If you could get rid of that womb, a woman could function with logic and reason like a man. That is the central theme through Western society. This is not a theme that's present in all societies around the world. It is a central theme of the Western societies. In the 1890s to 1903, attitudes became more enlightened, but with the crash of the stock market, the stereotypes returned. So how did medical people view the uterus in the middle 1800s? Well, Hollick in his Diseases of Women says the uterus, it must be remembered, is the controlling organ in the female body, being the most excitable of all and so intimately connected by its numerous nerves with every other part. Now, there's a very famous graduate of the Stanford Medical School, Archie Bunker, who said women were created for two things, making meals and babies. I actually change that joke wherever I go. He's the graduate of Ottawa's medical school, you know, wherever, just to loosen people up. But let me tell you a really cogent quote, and then we're going to move on to neurotransmitters. And that is that your average menopausal woman read this during the sexual revolution during her college years. And that's David Rubin in Everything You Always Wanted to Know About Sex But Were Afraid to Ask in 1977. Now, to put this in perspective, I went to medical school from 75 to 79, and I'm 42 and was young for my class. I should have been 44 or 45. So if that gives you some sense of the age of women and men who read this book. He said, as the estrogen is shut off, a woman comes as close as she can to being a man. Increased facial hair, deepened voice, obesity, and the decline of breasts and female genitalia all contribute to this masculine appearance. Coarsened features, enlargement of the clitoris, and gradual baldness complete this tragic picture. Not really a man, but no longer a functional woman. The postmenopausal woman will just be marking time until she follows her glands into oblivion. Now, you have to understand, I trash everybody in this lecture. No one's safe. The Greeks, men, psychiatrists, psychoanalysts. You know, what you have to do is understand that everybody had very bizarre thoughts. In the 19th century, the explanations for a mood disturbance by people in the field of psychiatry was cerebral congestion, retention of poisonous material owing to the non-functioning uterus, abnormal intestinal fermentation, and reflex excitability secondary to ovarian dysfunction. All right, here we are. What do we think is true? Evidence suggests that estrogen enhances mood in a dose-dependent manner and impacts verbal function, verbal memory. Estrogen receptors are throughout the brain, and by the way, they're throughout the male brain also. The postmenopausal or the andropausal male actually has more estrogen, circulating estrogen, than the untreated postmenopausal female. And it's not that you all got feminized, but we both need a certain amount of the other hormone. And what changes is the sensitivity and receptors throughout our body. Women need testosterone to drive libido, and it causes other effects in a woman's body, and men need estrogen to function. It's just how it affects you, and the doses you require are different. Estrogen receptors in the brain are in the pituitary, the hypothalamus, the limbic forebrain, the cerebral cortex, and the hippocampus, which is not in that list there. Well, let's start with mood. All right, now you're in med school. So do this or raise your hand if the thoughts or the ideas are moving too fast for your level of training, okay? Because I'm sort of used to teaching people internship level and above. But I think you're going to follow this, so I think we'll be okay. Estrogen impacts the availability of catecholamines. Catecholamines are what I make my living on in psychopharmacology. It is what the psychiatric drugs impact. And that is serotonin and noradrenaline. The tricyclics, the SSRIs, all these drugs play with those two neurotransmitters. Now, there is an enzyme in the neuronal ending called monoamine oxidase. The responsibility of that enzyme is to break down the catecholamines. So if you have a neuronal ending, if you have your receptors, and you have a synaptic cleft, right? And by the way, I'm not doing this for you. I teach attendings at Kaiser this way. You know, when I don't have a chartboard, it's the best way to do it. All of my drugs keep serotonin, depending on the drug, or noradrenaline longer in the synaptic cleft to work on the receptors. The monoamine oxidase sits in the neuronal ending. Estrogen, it turns out, decreases its activity. So if you decrease the activity of something that breaks down serotonin and noradrenaline, what's going to happen? You're going to have the stuff around more. And there's old drugs we don't use anymore, except for probably a couple of researchers and people working on refractory depression in an academic setting. That's Nardil and Parnate. And what were they? MAO inhibitors. So estrogen is a weak antidepressant through decreasing the activity of MAO. And interestingly enough, progesterone does the opposite. And that has to do with the whole PMS story that we're going to get to. But estrogen does something else very interesting. Estrogen regulates the quantity of free tryptophan getting to the brain through the blood-brain barrier. Tryptophan is a building block of serotonin, which is the main player in mood modulation in your brain. So estrogen increases the perfusion of that building block, and interestingly enough, progesterone decreases it. And then lastly, in surgically menopausal women, they were able to look at tritiated imipramine binding sites on platelets as a measure of serotonin transport, and they were able to show that serotonin transport increases in the presence of estrogen, decreases in the presence of progesterone. Now, this story is all going to fit together as we get to the end of the lecture. So it's hypothesized that a significant factor in the impact of estrogen on mood is on the serotonergic system. This is a term you're going to hear a lot in the next 8 years throughout med school and residency. Research has implicated that decrease in central serotonergic activity is part of the etiology of premenstrual dysphoric disorder. That is, your follicular phase is the first 2 weeks of your menstrual cycle. Mid-cycle is ovulation, when you can get pregnant when you drop the egg. The last 2 weeks is the luteal phase. The last week is called the late luteal phase, the week before your menstrual cycle. 8% of women develop a major affective disorder just in their late luteal phase that resolves completely within 1 day of starting bleeding. It's premenstrual dysphoric disorder. It's only 8% of women. Despite all of your personal experiences, 92% don't have it, okay? And I could prove that to you if I had a whole hour to do a PMS lecture. And those 8% have a disorder of their ability to modulate serotonin in the face of subtle chronobiologic change of hormones. Because understand that the human race has been around a long time, and there's been millions of years for us to develop the capacity for the brain to be plastic with chronobiologic change. Now, what do I mean by chronobiologic change? I mean menstruation, I mean pregnancy, I mean menopause. So what I'm trying to teach you is that most women do not respond to hormonal change with mood change. But there is a certain cohort or subpopulation that does respond, whose brain doesn't tolerate the subtle change. And that's part of what we're going to be looking at today. Now, how did they study this? There's a very famous woman in Montreal named Barbara Sherwin who's been looking at this for about 15 years. What she did is she said, menopause is too complicated to look at. There's too many variables. So let's look at women who's had their ovaries removed, who are non-depressed, have no history of depression, and are not in a depressing situation like cancer. So it's a very sort of clean, accepted operation that they're comfortable with. And what she found out is that if you remove a woman's ovaries and do an oophorectomy, post-oophorectomy, if you give placebo, she feels slightly sad and blue, but she does not have a depression, and she does not have a low-grade depression, and she does not have an anxiety disorder. But if you ask her, she feels slightly sad and blue. But as regard to the normal population, she's within normal limits. If you replace with estrogen to her normal estrogen level that she had before, that the ovaries were producing prior to the oophorectomy, what happens? She feels fine. And more interestingly, if you replace with estrogen and testosterone, her libido is maintained at the preoperative levels. Now, you haven't learned this yet, because even most people in residency and tendings don't know this, but there are two sources of testosterone, or precursors of testosterone in a woman's body, the adrenals and the ovaries. If you remove the ovaries, it's different from menopause, because the cells that produce testosterone, that are the libidinal drivers in women, survive the menopause. They don't survive it completely, as opposed to the estrogen-producing cells that are gone the minute you stop cycling. And lastly, I want you to take this as a take-home. It's a very important message. Major depression and dysthymia will not get better on estrogen. Estrogen is a very weak antidepressant. It only will repair when you feel slightly sad and blue as a result of changes in hormonal levels. Now, that's not to say that if you're getting IVF and someone gave you Fertinex, which is a drug that increases your ovarian production of oocytes, and you end up with 12 eggs developing at one time, and your progesterone levels shoot up to 1,200 from 300, and then you make the mistake of having a glass of wine at dinner that further shoots it up. If you got a little hypomanic, don't say Leventhal said it's just a weak antidepressant, because then you're having extraordinarily high doses of estrogen. But normal doses of estrogen that we would supplement with in the menopause and give women is only a weak antidepressant, will not cure major depression. Now, what about progesterone? Progesterone has potent anesthetic effects. In fact, the reason you're so sleepy in your first trimester of pregnancy is progesterone. It's a GABA agonist. It works on the same part of the brain as Valium. And then what happens is you feel better by your second trimester, and then you're in lousy shape by the third trimester because the baby's big, you're heavy, and you're exhausted from not being able to sleep, and the kid kicks every time you fall asleep. But it's a different issue. Progesterone in lower doses can cause variable amounts of dizziness, and it can affect deep sleep. Progesterone replacement causes irritability and dysphoria, and it's not uncommon for a woman to get a Depo-Provera shot either for birth control or to reduce ovarian cysts or reduce fibroids and end up in the emergency room suicidal with no psychiatric history. That is because a certain percentage of women are progesterone sensitive, period. And those women don't tolerate combined hormonal treatment of estrogen and progesterone, and you have to do creative things with them because you can't give them the progesterone. Does anyone here know why we give progesterone with estrogen in HRT? I'd be very surprised you haven't gotten there yet, but there's only one reason. Progesterone is a fetus's and a uterus's best friend. It is not a woman's best friend. And that's how you remember that the reason we give progesterone is unopposed estrogen causes uterine hypertrophy that can lead to cancer. So you got to add the progesterone. But remember that the cardiovascular system doesn't like progesterone. It's a constrictor and it affects HDL as opposed to estrogen, which is a dilator. The brain doesn't like progesterone so much. So what about the menopausal controversy? Well, there's three ways that you can get mood change in the menopause. We'll get there by one. There's three ways we can get mood change in the menopause. It's the domino theory, the changing estradiol level theory, and the stage of life theory. And I'd like to take you through that. The main way your patients are going to have mood changes in the menopause is not going to be my sophisticated arguments of women with subtle sensitivities to neurotransmitter change in response to subtle decline of estradiol. That represents a very small percentage of women. The fact of the matter is most women have mood change in the menopause because they're exhausted. And why are they exhausted? Because decline in estradiol causes thermoregulation changes and thermoregulatory instability in the hypothalamus. And that is also variable genetically from person to person. But the people who are unlucky enough to sweat and soak their night clothes will get such a disrupted sleep pattern that they're exhausted, and this will cause the mood change. However, I would point out to you that even subsyndromal hot flashes, such that the woman says, but I sleep all night, I just feel a little hot. If you study it in a sleep lab, you'll see that it affected the sleep cycle and it's still non-restorative sleep. Now, I'm hoping I'm making this point very clearly. Just because something happens doesn't mean it's clinically significant. So watch out when people give you lectures and you walk away thinking, God, that means every woman who has a hot flash at night has non-restorative sleep and becomes irritable and has difficulty functioning. You have to realize that there's tremendous genetic variability. So one person can go out without sleep very well and function very well. That would be my cousin Jürgen, who's a surgeon who gets 3 to 4 hours of sleep a night and actually is very mood stable. Then there are other people like me who was ready to cry the entire year as a Bellevue staying up all night every other night because I don't do well with sleep deprivation. So, you know, it's real variable. And so what happens is the degree of your hot flashes is not the only determinant of whether hot flashes and sleep deprivation is going to cause mood change. It has to be the hot flashes in combination with your vulnerability, mood-wise, to sleep deprivation. And that's what's going to separate a lot of you out in terms of the fields you go into. I got honors in surgery, but the guy gave me honors and said, but I don't think you're meant for surgery because you're terrible at 3 o'clock in the morning. I used to fall asleep holding the retractors at PNS. You know, so just because you're good at something, you may have biological factors determine what you go into in medicine because you don't function so well in the middle of the night. And I use that as an example for med students for you to remember that everything is not the same for all women in the menopause. Daytime hot flashes can cause an anxiety disorder. Imagine Marcia Clark during the closing arguments of the O.J. Simpson trial. She has a significant hot flash, her hair gets soaked, and her nipples are showing through her silk blouse. This is not going to look good on national television. But not only is it not going to look good, but the poor woman will probably develop an anxiety disorder. Why? Because a hot flash is an unpredictable intermittent stimulus. Like panic attacks, it can cause agoraphobia. Unpredictable intermittent stimuli are the best stimuli to create anxiety in human beings, as well as dogs. It came from Pavlov's work. So, and that is not to say there's any similarity between human beings and dogs. So what about vaginal dyshydrosis? Declining estrogen levels cause vaginal dryness through how estrogen affects the vagina and lubrication. And so you can have marital problems starting in your 40s because the woman may want to have sex, but it hurts every time and she doesn't know why. So she starts to decline, and this can destabilize a marriage. Now let me tell you about, let me go over, you have to press hard here. Okay, there it goes. You probably all don't know what a hot flash is. Some do. I see a few people give me this knowing look, but the rest of you are too young. And I got to tell you, I didn't even know what menopause was when I was in medical school. What year are you in med school? Second year? Third? First? Okay. You could be smarter than me. You got into Stanford. I only got into Columbia. But I didn't have a clue what a hot flash was when I was in med school. You know, so I don't know. Anybody here know anything about a hot flash except if your mother told you? Yeah, see, it's not, do you know we have attendings that don't have a clue what a hot flash is? Except if they're female. It's very, very important because the most significant morbidity in the menopause to cause mood disturbance is a hot flash. It's an initial sensation of pressure in the head followed by a sensation of heat in the head, neck, upper chest, and back, which can spread to the entire body. Objective measures are changes in skin temperature, resistance, and core temperature. Now the mechanism, the current theory, is that brain catecholamine and opiates are the possible mediators, and that the loss of ovarian function leads to a reduction in hypothalamic opioid tone, and that results in thermoregulatory instability. Now remember again the point I'm driving home, there's going to be tremendous genetic variability of each woman's sensitivity in her hypothalamus to a decline in estradiol, and that is why there is a wide range of symptoms in hot flashes. Yeah?
When you say thermoregulatory instability, it's like you're talking about the set point for thermoregulation getting changed around?
Yeah, it's not stable anymore. And I'll go on to tell you what happens. You can have hot flashes from less than daily to 3 per hour, a mean of 3.3 minutes, and a range of 0.08 seconds to 60 minutes in duration. The incidence depends on the country. Canada and the United States and the Netherlands is 65%, and Japan and Asia is 19.6%. Does anyone in here know why Asia has less hot flashes? Yeah.
Soybeans.
Absolutely. Soybeans have phytoestrogens. Usually drug companies feed you at these lectures, and I say you get extra dessert for that, you know. Soybeans have phytoestrogens, and they eat 2 to 3 pounds of soy product a week in Asia. And they're getting enough phytoestrogen to actually impact the effect of the menopause. Now there's something else that you may learn about in med school if they start teaching it yet. But the latest research also shows that soy product produces something called isoflavones that break down in your GI tract to something called genistein, among other agents. It turns out that these things are highly, highly anti-cancer and anti-atherosclerotic. The Asians have a 70% lower prostate, colon, and breast cancer rate than we do. And we're now attributing it to the high amount of soy in their diet. And then there's something else that's in the surface of grains called lignans, which have the same effect. The Finns still eat unmilled rye bread, and they have a 50% lower rate of prostate, breast, and colon cancer. So you're probably going to hear more about this over the next few years. Yeah?
Well, the incidence of stomach cancer is really high in Asian countries, so is the isoflavones not affecting the GI tract that high up?
It's unclear, because the isoflavones are not affecting all the cancers. Like, for instance, it seems to have no impact on pancreatic cancer. So where the research is now is that it's very, very clear, because they've done animal model studies, that the isoflavones and the breakdown to these agents in the gut and your microflora are affecting cancer rates, but not uniformly all types of cancer. And it's going to have to fold out. It's become a very, very hot area of research in the last 3-4 years. And the age of onset for hot flashes can be the mid-40s, but it can be as early as the 20s to the 30s. Now, we're going to run out of time, so what I want to do is make a couple of points. I'm going to go ahead through the slides. I want to go forward. Stop there. There is an argument coming from the NIMH that there's a big controversy. Can you get a depression de novo in your menopause? And the answer is we don't know. There's as much evidence to say there's an increased prevalence as a decreased prevalence. So what I'll leave you with is the research is almost impossible to do. We may not know for another 10 or 15 years whether there's any percentage of women with no history of depression that are getting major affective disorder in the menopause. And the reasons why are right there. It's complicated by contemporaneous variables, middle age and the vicissitudes of aging, the perception of menopause as a stressful life event, concurrent physical illness, and then hot flashes. It's extraordinarily difficult research. Stage of life, of course you can get depressed in the stage of life, but people overemphasize that. Mid-age is not such a terrible stage of life. And the research is showing that only a small percentage of women are having mid-age problems, and those women do not need to go to a psychiatrist. We want to send everybody to a psychiatrist these days. I mean, frankly, if I just treat depression, 2/3 of depression in this country is undiagnosed. So if we were to just start diagnosing the biological illnesses properly, I wouldn't have room in my practice. We don't need to send everyone with stage of life problems in our society to psychiatry. Where they belong is in women's health groups, at the temple, at the church, with friends, working out the stage of life the way we've always worked out stage of life problems through history. But remember that it can be an issue. Now, I want to leave you with the concept that with a predominant mood change in the perimenopause is not going to be psychiatric. Now, understand that we're doing such a poor job diagnosing depression in this country, and depression is prevalent in women at a ratio of 2 to 1 to men. So it means we're really doing a bad job on women diagnosing depression, though it's not on purpose. The fact of the matter is that many women will present in menopause saying they're depressed, but what they have is an undiagnosed depressive illness in the context of the menopause. So if you remove all the women who never got diagnosed that are presenting in the menopause, what you got left is that group of women, which is probably 15 or 20% of the total menopausal population, that are highly sensitive to change in estrogen. If you did the Zung, the Beck, all these measures of depression, they would all say they ain't depressed. But those women will sit there and say, I don't feel right. If I'm not depressed, tell me why I cry to a sad story on TV more than I used to. Tell me why I'm more irritable. Tell me why I don't feel right. And the reason why is they have subsyndromal symptoms of change in estradiol, just like Sherwin's work with post-oophorectomy. And the treatment for these women who are so sensitive is to put them on estrogen early in the perimenopause. Now, I want to leave you with one more thing, and that is you're going to hear more and more in the next few years about the effect of estrogen on the hippocampus. Estrogen affects the amount of neurotransmitter available, called acetylcholine, affects memory. Estrogen also affects dendritic connections. If you sacrifice a rat off of estrogen, it has less dendritic connections than a rat on estrogen. Again, is this clinically significant? Are all the women over 50 running around demented because they're not on estrogen? The answer is, of course not. It's not clinically significant. But if you did prospective testing on those women, you could show that their short-term memory is slightly impaired compared to the way they used to be, but they're within the norm. However, most of the neurologists will send back your patients on estrogen if they're demented, because an ill brain can benefit a lot from a slight improvement versus a healthy brain where the slight decline is not significant. So what I want to do is to wrap up with sex and culture. And what I want to tell you is sex is very impacted by the menopause, and that too could get a whole hour's lecture, but it's only getting one slide. Estrogen affects sex drive because the health of the vagina is affected by estrogen. Lubrication in the vagina, thickness and health of the skin going all the way up the vaginal canal, sensitivity of the pudendal nerve innervating the clitoris to have a good orgasm, all of this is impacted by estrogen. Blood perfusion to the vagina goes down 50%. So for those reasons, even if a woman's had breast cancer or she's against the idea of taking systemic estrogen, it's still a good idea to always inquire about her vaginal functioning and give her estrogen locally. In other words, you don't have to throw out the baby with the bathwater. You can estrogenize the vagina for sexual functioning, even if there's compelling psychological or opinion reasons or medical reasons not to put her on systemic estrogen. 20% of women, their testosterone production by their ovaries will be insufficient to drive their libido over the age of 50. And with those women, you need to supplement with testosterone. There are many studies that have showed that there's an inverse relationship between marital arguments and sex. That is to say, the less sex you have, the more arguments you have. Now, in a very good marriage, it's not so good to stop having sex. But in a bad marriage or a relatively unstable marriage, it will further destabilize the marriage and result in divorce. And the idea is wellness and health. And as a physician, your job is to keep the whole family intact if you possibly can. And lastly, sociocultural aspects, diet, environment, culture, herbal remedies, and old wives' tales all affect the menopause. Your patients will come in on Chinese herbs. Why? There's 3 Chinese herbs that are vasoconstrictors that are very helpful in controlling hot flashes. What are they? Dong Quai, remifenin, and black cohosh. So they're great for the woman whose mood is fine, having a few hot flashes, who doesn't want to take estrogen or 40. Send her to the health food store. Acupuncture is somewhat helpful, and if she drinks a lot of soy milk, the phytoestrogen will help. Biofeedback is time intensive, but it will help. The homeopathy and naturopathy research is so-so, so at this point I don't have an opinion on it. Papaya and soybean have phytoestrogen. The Mexican yam does not. The reason people think it does is because one of the estrogen supplements that we use comes from the Mexican yam, but it's synthetically derived. Exercise will increase your catecholamines, will make you less depressed, and will also give you more testosterone. So if you find that your sex drive has reduced throughout medical school, and if you find you're slightly depressed but you don't need psychotherapy, if you just got on the VersaClimber for 20 minutes every day, you might feel a touch better. Research is absolutely clear about this. And lastly, I want to close with the fact that the menopause is not the same worldwide. In 2 studies done by Flint in India and Mayos in Israel, the conclusion was middle-aged women in each culture respond to the menopause as their respective cultures set them up to respond. In India, they found that a well-nourished, rich caste in Rajasthan, Himachal Pradesh, was thrilled to be menopausal. They could take off their veils, they could joke, they could drink home brew, and they could get out of the women's quarters. In contrast to the U.S., American woman's status has not changed to a higher level. If anything, she's aging and declining, and her changing roles in middle age are not valued by culture. Now, how is this explainable if we're describing a biologic phenomenon? The reason is because all biologic phenomenon can be interpreted differently, or physical phenomenon. If I had a glass of water that was half full, I could describe that glass as being half full or half empty. The physical fact is it might have 4 ounces of fluid in it. A half full glass is more of a depressogenic view. A half-empty glass is more of a depressogenic view, and a half-full glass is less of a depressogenic view. So the point is that menopause can be physically experienced the same way, but in one place you could be saying, thank God it arrived. And the other place you could say to yourself, this is the beginning of the end, depending on the cultural context. So let's wrap up with what we're trying to do with all this. Well, this is the old view, of course. The ovaries, after long years of service, have not the ability of retiring in graceful old age, but become irritated, transmit the irritation to the abdominal ganglia, which in turn transmits the irritation to the brain, producing disturbances in the cerebral tissue, exhibiting themselves in extreme nervousness or an outburst of actual insanity. And what's the new view? The new view that we're trying to develop actually at Kaiser Permanente, because it's a wonderful setting to develop this kind of thing, because everybody's on salary, so there's tremendous, the more you cure people, the less work you have, and when you're on salary, this is a good thing. When you're in private practice and your practice is a little thin, it's not that you actively don't want to cure people, but you sure like a lot of visits. So in our system, we're very happy to get people in and out and well. So the best way to treat the menopausal woman is to create the virtual menopause clinic through email, group practice, and consults, and easy availability among psychiatry, internal medicine, family practice, and gynecology. You can provide a sort of overall care of the woman, every aspect, whether it's osteoporosis, breast cancer, menopausal change, hot flashes, mood change, comorbid presentation of depression and menopause. The idea being that you're giving a team practice. And every woman needs to be treated as an individual. A black woman doesn't get much osteoporosis. A woman with a history of depression may be exquisitely sensitive to mood change with hot flashes. An Asian woman may not have hot flashes or cardiovascular illness, but she may be vulnerable to osteoporosis. In other words, we ain't all the same. So the decision tree was, as you saw there, and then there's an upside-down slide. The upside-down slide basically says what I just said, and you want to rule out for major depression, you want to rule out for suicidality, you want to look at the domino theory and treat the hot flashes, and what you want to do is refer women with stage of life problems to support groups, not psychiatry. Overall, the take-home is menopause, the Greeks were wrong. Most people go through menopause without a problem, but our job is to treat the patients with a problem. This is what medicine's all about. We don't treat the whole population. We treat just the people who get sick. Our job is to treat the 5 to 20% that are going to have a difficult menopause for whatever reason, including mood problems, and understanding how to do so. And that was the focus of this lecture. The other 80 to 85% are just fine. They could be president of the United States. I'm not sure they'd want the job. And the Greeks were wrong. We are capable of logic and reason, and the men are capable of magic and intuition. And thank God we're all capable of both. Thank you.